Good morning, everyone, and welcome to today's webinar, Adverse Outcomes in Infertility. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance today will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. The certificate will be emailed to you by Harvard around midsummer. Oh, wait, sorry. It still says that people are on hold, so hold on, let me start this. Oh, maybe we are started. Okay, now, without further ado, I would like to introduce today's speaker. Dr. Donna Session is a board-certified reproductive endocrinologist at Wilmington Fertility Center, a Boston IVF center in North Carolina. Dr. Session joins Wilmington Fertility Center from Vanderbilt University School of Medicine, where as director of the Division of Reproductive Endocrinology and Infertility, she specialized in all aspects of fertility treatment, and she offers 25+ years of experience to those who wish to build a family. We encourage you to submit questions to Dr. Session using the question section of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the questions and answer session at the end of today's presentation. All right, we're about to get started. I'm going to pass it over to Dr. Session.
Hi, good afternoon, everyone. Today I'm going to talk about adverse outcomes due to infertility and its treatment. I have nothing to disclose. The things that I wanted to cover this afternoon are going to be complications of assisted reproductive technologies. We'll start with that. Perinatal outcomes, including multiple gestation, low birth weight, preterm birth, and miscarriage. We'll talk about congenital birth defects related to infertility and to the treatment, maternal cancers, and then we'll end with a brief discussion about imprinting disorders. So complications of assisted reproductive technologies. This study included 2,495 cycles in Holland. The greatest risk with IVF was ovarian hyperstimulation, more common in patients with polycystic ovarian syndrome. So in the oocyte retrieval, we use a 17 gauge needle. Most of those times they're going to be transvaginal. So there are small risks of bleeding, infection, injury to organs. The ovaries are enlarged after the retrieval, and so there is an increased risk of adnexal torsion in these patients, but only 2 in this study. And then they had an incidence of ectopic pregnancy of 2%. The good news is that the risks with ART are declining. So this was a study where we looked at the CDC data over a 10-year period with over 1 million cycles. Ovarian hyperstimulation and hospitalizations were the most common risks, and that their rates were declining, so lower hospitalizations over that time period. And then in the prior study, the ovarian hyperstimulation was 0.7%, and here it was down to 0.2%. So ovarian hyperstimulation is related to ascites, and then the patients become intravascularly depleted. One mechanism is through VEGF. Typically, it's detectable about 5 days after the oocyte retrieval, and if the patient's not pregnant, resolves by the next menses. Because it's usually detectable by 5 days, if the patient still desires an embryo transfer and may be at risk, I'll do an ultrasound on the day of the embryo transfer. If there's evidence of ascites, we are more likely to freeze all of our embryos to lower the risk. So the risks with this are going to be thromboembolic phenomenon due to being intravascularly depleted, electrolyte abnormalities, hyperkalemia, hyponatremia, and then end organ failure, liver and kidney failure. The risk factors for hyperstimulation are mainly related to the number of eggs. So if the patient has a high antral follicle count, if the patient has PCOS, a high AMH, those are all associated with a greater risk of ovarian hyperstimulation. Estrogen levels, if they're over 3,000, are at a greater risk, and if they have a high number of follicles or high number of oocytes retrieved over 25, they're at increased risk. Patients who've had a previous episode of ovarian hyperstim are at increased risk, and then if the patient becomes pregnant, it continues. And so it's related to the ovulation. If the patient has an LH surge or if the patient receives HCG. Since HCG has a longer half-life, it will continue longer. If the patient freezes all of her embryos and does not become pregnant, it's going to resolve relatively soon. If she becomes pregnant, it will be longer. There are a number of strategies to reduce the risk of ovarian hyperstimulation. And so one is to recognize those risk factors, have minimum dosing of medication, and so not to have so many oocytes retrieved. The use of metformin in PCOS is well established that lowers the risk of ovarian hyperstimulation. GnRH antagonist protocols have a lower risk than agonist protocols. In Europe, they'll use 100 of aspirin at the start of a cycle, and that has been shown to have a lower risk. I usually start aspirin the day after oocyte retrieval, just because I'm concerned about increased risk of bleeding with the oocyte retrieval, but that way may reduce the risk of thromboembolic phenomenon if we are concerned about ovarian hyperstimulation. We'll monitor cycles with ultrasound and estrogen. Again, we're looking for high number of oocytes over 25, estrogen levels over 3,000. And then if we determine that they may be at increased risk, we have strategies to lower those risks. So one, as I mentioned, is freezing all the embryos to avoid pregnancy. The use of cabergoline has been shown to reduce the risk of ovarian hyperstimulation. So cabergoline affects VEGF. It needs to start at the time of the trigger, and it's 1 a day for 8 days. I think what has probably really lowered the rate of ovarian hyperstimulation has been the leuprolide trigger. And so LH has a short half-life, and so this will, the ovary size of ovaries and ovarian hyperstimulation will resolve fairly quickly with a leuprolide trigger as opposed to an HCG injection. With the leuprolide trigger, there's going to be lower chance of pregnancy because of the levels of progesterone and estrogen in the patient. And so in those patients, we generally are not going to go ahead with a fresh embryo transfer or freeze all the embryos, but in those patients where you're concerned about ovarian hyperstimulation, we're generally not considering a fresh transfer anyway. I wouldn't say that, you know, you can't say it's completely eliminated the risk of ovarian hyperstimulation, but I rarely see it anymore with these strategies. The last time I had a patient admitted for ovarian hyperstimulation was, I think, in 2015. Okay, next we're going to look at birth weight, preterm birth, and miscarriage. So we know preterm birth is one of the largest contributors to perinatal morbidity and mortality. And it's been well established that IVF is associated with preterm birth and low birth weight. Okay. The other good news is that these risks have been decreasing. This was a study, the Nordic trial. It was over a 20-year period. And they had noted a decrease in preterm birth, very preterm birth, low birth weight, very low birth weight, and stillbirths. And they concluded in the study that the beneficial effects were mainly due to the increase in single embryo transfer and lower rates of multiple gestation. This is data from the CDC. This is public information. The IVF programs report their data to the CDC each year. And you look over time, the number in green is the number of singleton live births, whereas in the circles is twin pregnancies, and then down the bottom is triplet pregnancies. So over time, the number of singleton births with IVF has been increasing. And we think this is largely due to the increased number of single embryo transfers. There has been some controversy about elective single embryo transfers, that patients should have some autonomy about the number of embryos to transfer, whether or not twins are really at a really high risk. Mainly these have been brought up by Norbert Gleicher, that elective single embryo transfer will reduce the chance of pregnancy. If we're looking at transferring embryos, a blastocyst embryo, if we reduce from a double embryo transfer to single, you do reduce the chance of pregnancy maybe about 10%, but you're going to reduce the chance of twins from about 50% down to about 2%. So the benefit seems to largely outweigh the loss in chance of pregnancy. We do know that identical twinning happens more commonly with a blastocyst transfer, and it has been brought up that there may be an increased chance of imprinting disorders in blastocyst transfer, so we'll discuss a little bit later on. All right, so in spite of the fact that there have been more elective single embryo transfers and reducing number of twins, when we look at the CDC data, the chance of pregnancy hasn't really been declining over that time. So we've been able to maintain similar pregnancy rates. The identical twinning hasn't been able to really be eliminated with a blastocyst transfer. So if you look here, this is what an embryo looks like on day 3 for a 3-day transfer, and then this is what an embryo might look like on day 5. So it makes sense that at the time of the embryo transfer, this embryo may be more likely to split than a day 3 embryo transfer. And this is all hypothetical, but at the time when we first started performing blastocyst transfers, there was one report where the identical twinning was as high as 14% I saw. And so the things that we have tried to do to lower this risk has been the use of soft catheters, rounded edges, slowly placing the embryo in the catheter and slowly placing the embryo into the uterus to reduce shearing forces. But it still remains higher. It may be around 2 to 3% chance of identical twinning for a blastocyst compared to closer to the natural risk out of day 3. We do know that even on day 3, that if we do ICSI, where we put the sperm through the zona, or if we do hatching, we might be increasing the rate of identical twinning at this time because of allowing the embryo to hatch. And the risks are, though, very small, those that are thought to occur with ICSI and those that are thought to occur with hatching. There was one study that was a database study that said that the increased risk of twinning with IVF is not as risky as those who with natural twins, but mainly because of the fact that they're going to be di-di twins with a splitting at this stage, and so will be lower risk twins, but the risk still remains. So if we look at preterm birth and low birth weight, a lot of this, as I mentioned, was due to twinning, but it's also been demonstrated in patients with singleton pregnancies. So in 1999, they looked at singleton pregnancies and showed an increased risk of preterm birth in these patients, both less than 33 to 36 weeks and less than 33 weeks. This data was also looked at with the CDC data and looking at birth weight less than 2,500, and in singletons it was increased with that, even in singletons. One of the variables that you have in the CDC data is the etiology of infertility, and many of the other databases don't have that information. And so in the study in 2002, they were able to look at male factor infertility, and they also looked at the risk in gestational carriers. And what they found was they didn't see the same low birth weights in male factor infertility and gestational carriers, suggesting that preterm birth, low birth weight may be related to the etiology of the infertility, not necessarily the procedure itself. And so what we did was we looked at the CDC data for the etiology of the infertility. And what we found was that birth weight less than 2,500 grams was increased in patients with tubal factor, uterine disorders, and ovulatory disorders. And where we didn't see we didn't see an increased risk of low birth weight in patients with, say, male factor infertility. I would caution using that data to say that we're not seeing low birth weight in patients with endometriosis, because the criteria for being diagnosed with endometriosis in there is not well characterized. This is what the program that puts the data into the CDC has decided what the diagnosis of the patient. So we don't know the severity of endometriosis or whether it was diagnosed surgically. So the patients with ovulatory disorder, many of those patients have PCOS, and they have greater risk in pregnancy for low birth weight, particularly obesity, hypertension, diabetes in pregnancy. The uterine disorders are mixed a lot, maybe due to leiomyomata, and the tubal factor is what we were focusing on in these studies. So after this, we looked at preterm birth in patients with tubal seeds, and we compared them to male factors. We didn't see this in the male factor patients, and we saw a higher rate of late preterm birth in patients with tubal factor compared to male factor. And we also saw an increase in early preterm birth, 20 weeks to 32 weeks in tubal factor compared to male factor. And then the next study we looked at was looking at donor oocytes to take out the oocyte factor, and we looked at good perinatal outcome being term births and birth weight over 2,500, and we saw that the good perinatal outcomes were lower in patients with tubal disease. And in addition, tubal disease has been associated with a higher rate of miscarriage, early and both early and late. So we know that tubal factor may affect implantation, miscarriage, preterm birth, and low birth weight. There was a systematic review that looked at reduction of miscarriages with treatment. And they didn't define how the patients were treated, whether it was salpingectomy or a tubal occlusion. All treatments were included, showing a benefit to treating the tubes prior to pregnancy. The ASRM really recommends salpingectomy for patients with hydrocele impinges prior to the IVF to increase chance of pregnancy, potentially lower chance of miscarriage. There is a concern that performing a salpingectomy may affect ovarian reserve. It's been tied to lower AMH levels, lower number of oocytes, and lower antral follicle count, but those risks are probably thought to be fairly low. When performing the salpingectomy, it's recommended not to use unipolar cautery to stay distance from the ovary to preserve the ovary and number of eggs as much as possible. And if it's not possible to remove the tube, you can leave a portion of the tube on the ovary if it can't be removed. In the data for the with the CDC, when we looked at preterm birth and low birth weight, the CDC did not want us to look at whether treatment lowered preterm birth or low birth weight or was affected by it, even though that data is collected in the CDC. It was not a data point that when they audit IVF programs that they validate, so they didn't feel comfortable that they can say that that information would be accurate. So we know that there's an increased risk of miscarriage for tubal disorders, and that treatment will lower it. Miscarriage has also been tied to diminished ovarian reserve. So patients with low AMH, elevated FSH, low AFC. And then there have been studies that have been associated with a higher rate of aneuploidy with pre-implantation genetic testing in patients with diminished ovarian reserve having IVF. The the incidence of miscarriage is not very high. We looked at this with the CDC data, patients with an FSH over 12, and there was a significantly higher rate of miscarriage, but it was small. And then there was a recent study from the Boston IVF group that was came out in September and was chosen by SRM to be a journal club. And they did not find an increased risk of aneuploidy in patients with diminished ovarian reserve. So a little bit controversial. It might have a slight increased chance of miscarriage, but it's probably pretty small. So miscarriage and PCOS, the patients might have a higher risk of miscarriage. Some of this is thought to be due to the presence of hyperinsulinemia, which causes progesterone resistance. There may be factors as far as obesity and inflammation and higher rates of loss in patients with PCOS. The studies on the benefits of metformin are mainly retrospective studies, and it's been somewhat controversial. The studies on the use of metformin to reduce late spontaneous abortion and preterm birth were, this was from this one author here that's done 3 different studies. The first 2 were combined, and we saw significant decreases in late miscarriages. I think they were considered 13 weeks to 20 weeks and preterm birth. So they did a follow-up study, which was randomized controlled study, and it didn't reach statistical significance. It was the p-value was 0.08. But I think there's going to be increasing data on the use of metformin to lower the risks of miscarriage and preterm birth. Again, one of the theories being the reduction in insulin resistance and progesterone resistance, but there's other theories on why metformin might reduce the risk of preterm birth. So moving on to birth defects affecting about 1 in 33 in the U.S., high rate of cost and leading cause of infant mortality. So looking at birth defects, we know that birth defects are increased in patients with infertility. This was a Netherlands based case analysis, and what they found was that subfertility was associated with increased risk of birth defects. So if it took more than 12 months to conceive naturally, there was an increased chance of hypospadias, abdominal wall defects, and right ventricular outflow obstruction. Then this study looked at subfertility and treatment. So subfertility was time to pregnancy greater than 12 months. For the treatment, they included surgery, hysterosalpingograms, IUI, IVF, and ICSI. And then what they noted that the longer it took to conceive, the higher the risk for malformations. And it was mainly genital organ malformations were associated with the infertility treatment compared to higher than those who conceived naturally. And this was a study looking at intrauterine insemination retrospective study. They had twice as many birth defects in the IUI as those who conceive naturally. They didn't see any difference in those who use assisted reproductive technology. And then these were mainly circulatory septal heart defects, and they found also a higher rate of musculoskeletal defects. Multiple birth is one of the confounding variables because twins have a higher rate of malformation than singletons. And in this study, they didn't find any relationship with infertility of their treatment. ICSI has been proposed to increase the risk of birth defects and to increase the risk of imprinting disorders. I think, you know, the studies that come out of the UK are probably some of the better studies because they have a developmental pediatrician there who was training nurses to do physical exams on the kids. So they would go to their daycares or on their homes and do, perform the physical exam looking for birth defects. And this one, it was a case control study. And they didn't find any difference in major anomalies. They were similar, about 4 to 5%. What they did find was there's a much higher rate of birth defects in men who were oligospermic compared to those who were doing ICSI for other reasons. So they had found it to be as high as 20.7% in those who had oligospermia compared to 8% who did ICSI for other reasons. Sorry. So the study from Australia was a birth registry study, and that was in the New England Journal of Medicine, and it got a lot of attention, this study. And so they compared ICSI with IVF compared to naturally conceived children, and they had a higher rate in the ART group, but the ICSI group and the IVF group were fairly similar, about 9% compared to about 4% of patients who naturally conceived. So they did not see any increase with the ICSI procedure. The weaknesses or limitations of this study, as a birth registry, they did not examine the children, and there were concerns that reporting might have been higher, so that the patients who underwent IVF were older than the patients who conceived naturally, and they also did not account for chromosomal abnormalities such as Down syndrome, and they counted each birth defect individually. So if you had a child with a syndrome, it amplified the effect by counting each one. There were differences in the gravity, whether or not they were in rural and inner city. So most of the patients who did IVF and ICSI were inner city patients versus the natural were more rural, and they didn't look at whether or not there was a difference in reporting of birth defects. And again, there was also a higher rate of chromosomal abnormalities in patients who did IVF and ICSI. This is a study from the University of Iowa, and looking at IVF and birth defects there. What they found was that an IVF is about 6%, IUI 5%, naturally conceived about 4%, and they found an increase in cardiovascular musculoskeletal defects. But they did not see a difference in rates after ICSI or with frozen embryos. One of the interesting things that they showed was that the birth defects were higher in male offspring versus female. So again, that would suggest that it wouldn't be the ICSI procedure itself, because then it should be equal, but maybe some underlying abnormality in male factor that's contributing towards these higher rates of birth defects. And that what they found was an increased risk of genitourinary defects, mainly hypospadias. Then there was a meta-analysis that looked at risk in sub-infertility greater than a year to conceive, and a 20% increase, and then a 30% increase in assisted reproductive technology. And the main risk that we see with ICSI was hypospadias. So what it seems to be, for me, as I think of it sort of as a dose effect, is that the worse the infertility is, the higher the rates of birth defects, probably because that the underlying etiology of infertility worsens. For example, that the sperm count's decreasing, and so the lower the sperm count, the more likely they need to use IUI, and if it's even lower, the more likely they are to use ICSI. So this is, our National Society's summary on birth defects. Is naturally it's about 4%, 3% for severe defects. In assisted reproductive technology, it's about 5%, 3.7% for severe birth defects. And most of the increased risk is due to the older age, aneuploidy, the etiology of the subfertility, particularly oligospermia and multiple gestation. Maternal cancers, we know that patients with infertility have an increased risk of breast, ovarian, and uterine cancer, and these are more common, particularly related to infertility. There are a number of confounding variables such as nulliparity, late age at first birth, the length of use of hormonal contraception and ovulation, and the use of imaging for detection. So this study by Whittemore got a lot of attention in the early 90s. So it was a case control series of over 2,000 cancer patients. And what they noted was a decreased risk of ovarian cancer with an increasing number of pregnancy, longer duration of breastfeeding, longer duration of hormonal contraceptive use, and tubal ligation or hysterectomy. They didn't see any relationship with age of menarche, age of menopause, or hormonal replacement therapy. And they did say that there might be an increased risk with fertility drugs, infertility, and this may be particularly related to the increased risk of nulliparity. So there are some limitations of this study, the main one being recall bias. So patients with cancer will dwell on what they've taken in the past and risks, and so they'll report using more medications than someone who does not have cancer. They also didn't verify in the charts what type of medications the patient took and what type of fertility drugs they may have taken. This study also got a lot of attention by Rossing, and so this was patients treated for infertility. I would point out the low numbers that they had, and also that they didn't have a control group. So there were 11 invasive and or borderline tumors, and they were compared to what would be the expected number. The relative risk with clomiphene was 2.3. There were only 5 of the 9 women who had taken the drug for more than 12 cycles, and they stated that treatment less than 1 year was not associated with an increased risk. So as far as the infertility and cancer, most of the recent studies show that the risk is related to the confounding variables such as the nulliparity. There does seem that there may be an increased risk with for borderline tumors. It hasn't been associated with a particular fertility medication, and the incidence is fairly low. The fallopian tube is a potential source of ovarian cancer, needs to be evaluated and looked at. In the past, it was thought that the fertility drugs role in ovarian cancer was due to incessant ovulation, but in light of the fact that most cancers are coming from the fibrillary end of the tubes, that it's not likely related to number of ovulations. Childhood cancers. There have been a number of databases that have shown an increased chance of cancers in children born from assisted reproductive technology, but the studies have varied. The numbers are really low, so when you have large numbers of patients in the studies, small differences become statistically significant. In addition, the types of cancers have varied, so that it questions whether or not that it is real. And then also many of these databases cannot control because it's not included in there as far as their etiology of infertility or subfertility. Imprinting disorders. This has come up because we see abnormalities mainly in mouse models. They've looked at methylation abnormalities. Interestingly, when the mice are looked at as adults, they may not have the same methylation abnormalities, so they thought perhaps there's some auto correction. But in theory, the reason why this is a concern is that most of the methylations from parents are erased during gametogenesis and early embryogenesis. And then there's a wave of methylation silenced genes that takes place around the time of the blastocyst. And that this epigenetic genetic program can be susceptible to the environment. So one of the factors was the use of serum in culture media, and we don't use serum in our IVF culture medium anymore. There were evidence that culture medium similar to the fallopian tube, where the oocyte is normally fertilized, might have lower risks. As I mentioned, there was concern about blastocyst transfer versus the day 3 transfer because of the onset of methylation, but studies have not seen a difference in methylation between day 5 and day 3 embryos. And there have been several imprinting disorders that have been tied to infertility and IVF that are listed here. So imprinting and subfertility, they found that methylation defects were more common in patients with subfertility, which I believe they considered greater than 12 months to conceive. So again, saying that the imprinting may be related to subfertility, not the IVF and culture media. And then it's also been described with oligospermia and with found in sperm in patients with infertility. So this study looked at the H19 gene that's related to weight, and I think it's been tied with Beckwith-Wiedemann syndrome. And in patients who had normal sperm numbers, they didn't see any abnormalities of methylation. If they had moderate oligospermia, it was higher, and if they had severe oligospermia, it was even higher. So it suggested that the abnormalities of genomic imprinting were related to the lower numbers of sperm. And there was another study that looked at a sperm from patients with infertility versus sperm from patients that did not have infertility, and they saw a higher rate of methylation defects in the sperm of patients with infertility. So for the imprinting disorders, the studies don't agree on whether disorders are associated with IVF or not. These disorders are fairly rare, maybe 1 out of 1,500 people. And then they may be associated with subfertility and oligospermia, not necessarily the IVF and the culture techniques. So summary of the talk is the risks of assisted reproductive technologies are declining, mainly due to the decrease in ovarian hyperstimulation and the increase in the use of elective single embryo transfer. Birth defects, preterm birth, low birth weight, and cancers may be related to the etiology of the infertility and the confounding variables, such as the age. As far as the childhood cancers and imprinting disorders, they're rare, and they don't all agree on whether or not they're related to assisted reproductive technology. And on the cancers in women, it's related to their infertility etiology, but there may be a slightly higher risk of borderline tumors in patients with infertility. And so it's not been tied to necessarily a particular type of treatment. Some of the studies have suggested that increased length of therapy, 6 cycles to 12 cycles, might contribute to that risk. Since most people conceive within 3 to 6 cycles of a fertility treatment, because of that potential association, it's better not to continue with fertility medications if it's not likely to be successful. And that's it.
Thank you, Dr. Sessions.
You're welcome.
We're going to now begin answering the questions submitted during today's presentation. As a reminder, you can still submit questions to the questions panel in your attendee controls panel. Dr. Session, our first question is, how do you help patients who are nervous to do IVF feel more comfortable with it?
Yeah, I tell patients that that the nurses and I will walk them through a cycle, that we do it step by step, and we're here for each of that step. I would say that again that what we're finding is that the risks related to IVF are much lower than it has been in the past, and those risks that we thought previously was related to IVF may be related to underlying factors for the etiology of the infertility, not the IVF procedure itself. And there's also benefit if that, it's faster to pregnancy, and we know that lower age at pregnancy, and pregnancies are protective for things like some of the cancers. So there are benefits to having the earlier pregnancy.
Thank you. Our next question is, at what age or under what circumstance would you recommend the implantation of more than one embryo?
So ASRM has a table where what number of embryos are reasonable to transfer based on age. And so if the patient has PGT for aneuploidy screening, it's always one embryo. I think that if the patients have poor quality embryos, if they've not had a prior successful cycle where they've had a pregnancy, and if they are not going to have extra embryos to freeze, then those patients, there's reasonable to transfer more than one embryo. And those numbers are going to be based on age for the number of embryos that are reasonable to transfer. So what ASRM has is sort of the favorable and unfavorable. And if they're favorable, we'll limit the number of embryos transferred. But in some unfavorable situations, we can transfer more than one.
Thank you. Our next question is, what is the reasoning for increased risk of SAB with PCOS?
So the theory, and that goes back to work by Linda DeGeest in the early 80s, is that in the presence of hyperinsulinemia, there's progesterone resistance. And that's one theory that is the association with miscarriage and preterm birth. And that by lowering the insulin levels, we can increase progesterone. So progesterone, even though the progesterone is being given to the patients with infertility, if it's not effective at the uterus, then they're going to have a higher rate of miscarriage and preterm birth. But there's also other theories with PCOS that they have increased obesity, and in case of obesity, it may be inflammatory, and so there may be other etiologies of their increased rate of losses.
Thank you, Dr. Session. That was our last question. And thank you everyone for attending today's webinar, Advanced Outcomes in Infertility. If you have any other questions, please contact myself, Alyssa Cooper, at ecooper@bostonivf.com. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate it if you could complete the survey and provide your feedback to help with future educational webinars. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of Boston IVF, Wilmington Fertility Center, and Dr. Session, thank you for joining us today and enjoy the rest of your day. Thank you, Dr. Session.
You're welcome. Have a great rest of the day.